All right, I think we got a good number of people coming in. So I'm just going to go ahead and get started. So hello, everyone. Thank you for joining us today for this special webinar. I'm Dr. Joel Salinas. I'm a behavioral neurologist. I'm also co-founder and chief medical officer of Isaac Health. I'm really focused on things related to brain health and memory. That's kind of what I've built a lot of my specialty around, but I've also, but some of you might not know, I've been involved in research my whole career, and in particular worked very closely with the Framingham Heart Study to really understand the epidemiology of Alzheimer's disease and related disorders, and to understand psychosocial determinants of brain health. I've worked with many other studies as well in many capacities. So, being involved in research is something that I'm really proud of, and I also encourage a lot of patients to participate in, because this is how we develop kind of new treatments and develop advances in these conditions, and really help us to understand what causes the symptoms that people develop and the underlying disease processes that are happening in the brain. So today's conversation, we'll be talking a bit about kind of clinical trials and other types of studies, kind of what they are, how to get involved, and highlight some opportunities to get involved through Isaac Health and through ERG. We'll share a little bit more about that. And on that same note, I'm thrilled to be joined today by an outstanding expert in this field, and that is Dr. Payal Patel. Dr. Patel is a distinguished neurologist who's also specializing in cognitive disorders, including dementia and neuropsychiatry. She's also principal investigator at Brain Matters Research, which is a well-known research center dedicated to advancing clinical trials for Alzheimer's disease and other neurological conditions. So, Dr. Patel, thank you so much for being here today.
Thank you so much for having me.
We're always welcome to have you. Before we dive into our discussion, could you please share a little bit more about your background, what got you interested in research, and your work at Brain Matters Research?
Sure, absolutely. So I'll try to do this without taking up too much time. But as Dr. Salinas said, I'm Dr. Patel. My specialty is also cognitive behavioral neurology, which is a big fancy word for memory disorders. I am a board certified neurologist, and my interest in this field actually began when I was kind of divided between neurology and psychiatry. To be honest, I was looking in my training days at programs that were driven towards neuropsychiatry. And those programs, unfortunately, were dying, as I think that recognition for the connection between brain and mind was dying. So I decided to take a different route, and I decided to become a neurologist. I chose between neurology and psychiatry because I thought that neurology was more of an exact science, localization-wise. And I was really blessed to be able to complete a fellowship at Northwestern for cognitive behavioral neurology and able to specialize within my field of neurology on memory disorders. So I did that, of course, in Chicago. And after Chicago, and after having lived in Buffalo for many years, I decided I was going to leave the cold and come down to West Palm Beach, Florida, where I entered private practice and was the director of memory disorders in private practice until one day, Dr. Mark Brody, who is the founder of Brain Matters Research, approached me and said, "Well, how would you like to do clinical research?" And I said, I really don't know what this involves. I kind of had that same expression and reaction that many of you probably have. I don't know what this is. It feels a little uncomfortable because it feels different. But I decided to shadow for a day, decided to give it a shot. And I actually really love what I do, because not only am I able to give the same recommendations I could give in private practice, but I'm also able to give many more disease modifying therapy options through clinical research. I'm able to offer diagnostic clarification through clinical research at no cost. And we do this through something called the Know in 90 program at either one of our sites. So we have two sites, one in Delray Beach and one in Stuart, Florida. And we do complementary memory evaluations called the Know in 90 program, where we essentially see people like you who are concerned and want to either prevent or treat early Alzheimer's disease. And you know what I think the thing that I like the most about what I do is that we're not a research mill. We're not here to sell you on anything. We're not here to pull you into a clinical trial. I genuinely feel that the recommendations that we give are from the heart, and they sometimes aren't research, and that's okay. But getting in to see a neurologist takes time, and oftentimes it takes at least 12 weeks to see a neurologist for a new patient appointment. We're able to see patients generally within a couple of days. And that's really nice. I mean, just the ease of the process, quick diagnosis, quick intervention. Those are all things that I'm able to offer through this practice. And I'm so happy to be here to speak to you more about clinical research.
Thank you, Dr. Patel. I think what you highlight to me is that there is this kind of, it's a whole other uh, angle in care, right? Because it's not just kind of the study itself, but you're also providing counseling, you're providing resources, and you're helping to
Yes,
provide answers for people in ways that aren't available in typical clinical practice.
absolutely.
Wonderful. Well, why don't we just dive in and share a little bit more about kind of what we mean when we talk about kind of these different types of studies. So, I mentioned the word clinical trials and I mentioned observational studies. So just to kind of get some definitions out there. So clinical trials are research studies in which researchers assign participants to get one or more interventions to test what happens in people. In other words, a clinical trial is a study where you are doing something to an individual. It can include a medication, it can include kind of a behavioral program, it can be teaching. You kind of as a in the study that the design kind of decides what is that intervention. Whereas an observational study is a little different. These are research studies in which researchers only collect data from participants. In observational studies, researchers don't assign participants to get an intervention. So really the whole point of an observational study, as the name would imply, is really watching people over time and gathering different types of measures to really see how they progress, how kind of different factors play into their risks of developing disease, but also in terms of the likelihood of being protected from certain elements of disease. So it's both health and disease. And I like to think that both of these work hand in hand because it's the observational studies that help to inform kind of what potential targets there are that then inform the clinical trials. And clinical trials themselves can also turn into observational studies because we're also following people over time. So just some things to highlight in terms of clinical trials within this field. But clinical trials have led to some major breakthroughs within the world of Alzheimer's disease and mood disorders. In particular, many of you have heard me talk about this before, the new disease-modifying therapies, the new treatments that actually target the underlying biology of disease emerge from clinical trials, as you can imagine. There's three major phases to any clinical trial. There's phase 1, 2, and 3. Oftentimes, what you'll hear about in kind of media and news is the earliest phases of studies when they're working within animal models, for example, or the kind of simulations where there's some promising information. But when you get to the level of a phase 2 clinical trial, you're really looking at safety, efficacy. We're also just looking more than even efficacy. It's really what we call the pharmacodynamics, the pharmacokinetics. We're really trying to understand what happens to these substances in the human body. In the phase 3, that's really where we're looking at the question of efficacy. Is it going to accomplish what we say it should be accomplishing as a primary outcome? And the researchers then decide what is our main outcome, the main single thing that we're looking at, and then if we are able to accomplish that one thing, then we have a list of other things that we want to look for. Sometimes they're called secondary outcomes. And that can also help you do kind of other analyses to understand why a drug might be more or less effective in a particular group. It can also help us to just understand a little bit more about conditions because we have this additional data that's available. Why to participate in research? One, I think it really helps to provide hope for people living with these conditions and their family members. I see it as a contribution to the future of society. You are contributing to this large mission of people coming together to treat suffering, to treat conditions, and to help to improve kind of the human condition. It also allows people who have conditions to play a more active role in their own healthcare and to really play a more active role in kind of what happens within their lives. And it also gives you potentially access to treatments before they're widely available. And Dr. Patel can kind of speak to this, but when you go into a clinical trial, there's oftentimes a randomization that happens, and you don't really know where you end up in the treatment group or placebo group. Do you have anything you'd like to share, Dr. Patel, about kind of that experience on the patient side?
Yeah, that's a really tough one. So, I mean, we've been really fortunate. So, first of all, we were so excited about lecanemab and donanemab, and we were very fortunate because we actually helped to collect data for both of those studies and helped to get that drug approved, which is amazing because
Incredible. Part of history.
yeah, yeah. I mean, it's a wonderful accomplishment for all of us. But I think that's a really tough thing, and I think, we have to be transparent with our patients. You don't know what you're getting, whether you're getting drug or placebo. There are rare opportunities where you have open label, where mainly phase 3 studies where you're looking to gain rapid data on a large number of patients. And in order to expedite that enrollment, you provide, open label, which means all patients are receiving study drug and they know that, so that there's no blinding. Whereas most studies typically are double blinded, where we don't know what you're receiving and you don't know what you're receiving. And oftentimes we don't have that until the final data analysis occurs months after the study ends, whether that's because the drug has been approved or whether the study has ended because of lack of efficacy. We oftentimes don't know until much later on what the treatment assignment was. However, what I do say about clinical research is we do cognitive surveillance at key intervals, usually once every 3 months, most of the time once every 6 months. And I say that the decision to join clinical research is an evolving one. What is good on one particular day, 6 months later, 12 months later, may not be the right treatment, just based on what we see with progression as far as cognitive scores. And usually, I think cognitive behavioral neurologists especially have a good feel for what to expect, what would be normal without disease modifying treatment. So when we see, that same dip on disease modifying therapy, we might say, ooh, there's a possibility we're on placebo, but let's reevaluate. Let's see what our treatment options are. And do we need to add on standard of care treatment? Do we need to think about, ending the study participation? Whatever it may be. And I'm sorry if that was a long-winded answer.
No, it's a great response. I mean, I think this is a question a lot of people have when they're considering whether to go to a clinical trial is, what if, right? There's that big what if.
Yep.
There's so many what ifs that can happen, right? What if I get placebo? What if I get into the intervention group? What if there's a complication from the treatment? What if I'm missing out on some other treatment by being in the clinical trial? So thank you for speaking to all those points.
And then, like you said, with
So
the lecanemab and the
yeah,
donanemab, the biggest issue there is you're receiving these treatments and they're expensive treatments. We're looking at
mm-hmm,
$27,000 for lecanemab for the drug
right,
alone, and we're looking at
yeah.
$35,000 for donanemab. And I'm sorry if I'm skipping to something you have on a different
No,
slide.
no, no, you're great. No, you're good.
But that's a rate limiting factor, because many people, when you are on these drugs and you don't have drug stopping criteria and you are starting a drug that you may be on for the rest of your life, can't afford that.
Right.
And then there's obviously the added angles of, adequate safety surveillance, and then also adequate cognitive surveillance. How do you know that the
Mm-hmm,
treatment is working if you're doing this
right.
commercially?
Yeah, I've seen some patients that were started early on donanemab and lecanemab, and because they were in the clinical trial, not only at some point, right, they had the crossover, right, so they were able to get a guarantee that they were going to get treatment,
Hmm.
but they
Yeah.
also were able to participate in the open label extension. So
Yes.
for those of you that aren't familiar, an open label extension, or OLE, essentially what that means is that you continue to receive the intervention, you continue to be followed over time to really see the long-term potential risks and benefits. And as a part of that, you essentially get to continue to have kind of treatment without needing to pay for it.
Yeah. So actually, we have a study that is still ongoing with lecanemab. And those patients that are in that study, majority of them have switched to an injectable form of lecanemab. And that's super exciting
Wow.
because
Wow.
so the company's looking to present that data to the FDA to now say that the subcutaneous injectable form is equivalent to the infusions, thereby
Yeah.
increasing accessibility to patients who don't have access to infusion centers, and thereby hopefully improving cost as well, for the infusions, or the treatment, I should say.
Wonderful. Yeah, I mean, we need the data. Yeah, especially we're really kind of and everybody on this webinar, kind of patients and members included, we're all kind of pioneers on this frontier of understanding kind of what therapeutics in this area looks like, and kind of being able to participate in research as much as possible really helps us to understand long-term risk and benefits, but also kind of what's the impact on the health system. And that's a big question that will definitely come in when things like Medicare and Medicaid are thinking about how do we cover this? Do we cover more, and whether commercial health plans cover it, and whether policies should be emerging to help to provide more resources around this.
Yeah.
Great. So let's go dive into a little bit of the landscape around clinical trials today and how you can get involved. So this is just a sampling of some clinical trials that are open for enrollment today. So the first one that I'll highlight is one called the START study. That stands for Synaptic Therapy Alzheimer's Research Trial. And one of the things I love about the clinical trials and other studies is that the uh, the acronyms are a lot of fun. That sometimes they'll really come up with really really interesting names. And I don't know if Dr. Bill has any kind of like favorite trial names, but they get pretty fun and creative to be able to like figure out ways how they can use the word like unicorn.
Yeah, it's like progress and start and the evoke study and I mean
Yeah, yeah.
all kinds of funny names. Like, this is a good one because the start, the acronym actually kind of represents what the study is targeting, and this one is targeting synapses and essentially targeting oligomers, which are a form of the abnormal amyloid, and basically targeting this amyloid and keeping it from forming at the synapses. So you've
Mm,
got, the lecanemab and the donanemab, which are looking to clear amyloid plaque. And essentially, the easiest way I could put it is those therapies are kind of tagging the abnormal plaque, the abnormal protein,
mhm,
and essentially recruiting the body's natural waste system to identify that as a waste product and to dispose of it naturally through your, bodily system. So this
mm,
is kind of a cool option because remember, all three treatments, including aducanumab, which has now been withdrawn off the market, all three approved therapies are targeting amyloid. So this too is targeting amyloid, but is not associated with the same risk profile as far as swelling or bleeding in the
mm,
brain because of the abnormal amyloid that it's targeting, the oligomers. So
mm, mm.
kind of neat because if you can keep those oligomers and you can keep the amyloid from, forming at the synapses, the connections in the brain, then hopefully you can keep those synapses active and keep information and the communication active between brain cells and keep those brain
Yeah.
cells from dying away because of misuse or lack of use, I should say.
Yeah, yeah. And that really speaks to kind of a general kind of trend that we're seeing kind of within the development of these treatments. I think um, what ultimately kind of this care will look like probably in the next kind of couple of decades is kind of comprehensive protocols that involve multiple treatments and that
Yep.
is multi-pronged therapies, kind of like we've seen for a long time now within the field of cancer, right? They have uh kind of many different kind of acronyms for the different types of treatments like FOLFIRINOX and then a bunch of others like CHOPT
Yep.
and but the idea is if a disease process is very complex, let's target different steps along that process with these treatments to really help to improve the likelihood that a person is going to have improved function, slow decline, or slow disease progression, whatever the main kind of goal is there.
Yeah, it's kind
And
of interesting because this field is kind of like the MS field. When I trained, you had two options for
mhm,
treatment of MS. Same thing here. It's like you had two different symptomatic therapies, really. You had Aricept and Namenda. Then you had this 17-year lull, and then you have improvement of disease modifying therapies.
mhm,
And now you've got all kinds of different, agents that are on the market, including still other biologics, which are these monoclonal antibodies, but then a
mhm,
whole slew of other what are called small molecules like this that have all different types of mechanisms of action. So the next one on the list is a benfotiam study, which is an interesting study involving a high dose version of thymine called benfotiamine. And that's a really cool
mhm,
option as well because this has been studied for different indications in the past, peripheral neuropathy and so forth, and has like probably the safest side effect profile that I've seen with anything. There are no treatment emergent adverse effects. So that
mhm.
means no side effects that are, tracked or affiliated with the treatment. It is completely different mechanism of action because you're looking basically to see if you can increase the thymine content in the brain by 50 to 200 times that which is normal. You're looking to see if you can help supplement the brain's natural processes and the way it
Mm.
utilizes glucose to help improve memory and thinking. So again, like very neat, completely like out of this world a mechanism of
Yeah, I love
action
that.
that is exploratory
Yeah,
but
it's
safe.
very out of the box. Yeah, exactly. I think within these conditions, it's just so important to think beyond kind of the typical mind frame of like this is the day's pathology. We have to just target that one specific thing. And we need to kind of diversify the portfolio of potential treatments to really see where we can have the greatest kind of value for the intervention. And maybe it's a combination of things,
Yeah.
especially things that are low risk, unlikely to have kind of adverse effects, may potentially lower risk. I think that's a great intervention.
Yeah, and speaking to your point on combination therapies, what's interesting about those two options, the START study and the Benfo option, is that most of these protocols don't want confounding intervention. So they don't want patients who are on commercial treatment of lecanemab or donanemab. These two studies actually allow it, but you have to be stable on those
Mm,
treatments for 6 months
mm-hmm.
prior to entering the study. So I think that's super cool because I have patients who
Yeah.
come in and they're like, well, what's my best option? What gives me where do I have the best odds of receiving treatment? I've got something equivalent to cancer. I want the best chance of treatment. And I say, I'm going to be honest with you, it's commercial treatment. If you can afford it,
Yeah.
and if you feel comfortable, and if you can find a provider that you feel can safely manage you through that. However, an added option might be once you're stable on 6 months, now you've got dual surveillance if you enter one of these studies, which are fairly low risk, great side effect profile. And now you're getting, the
Mm,
biggest bang for your buck because you've got
mm-hmm.
definite
Mm-hmm.
treatment. And now you're adding on potential treatment. Of course, we don't know. There's a possibility of placebo versus treatment. And it's
Mm-hmm.
a
Mm-hmm.
2 out of 3 chance of receiving treatment, but those are pretty good odds.
Yeah, yeah. It's
Um,
the potential for an enhancement, right? In terms of what you're doing already.
yes, yes. Yep,
Great.
these are classified as cognitively enhancing treatments. And then you've got the HOPE study, and I'm not sure if you wanted me to go
Mm-hmm.
into that one just yet.
Yeah, go for it. Yeah, please.
Okay, so the Cognito study is one that you guys may have heard of. I'm not sure. I think that they've had some sponsor-proof campaigns, but essentially it's a device that you wear on your head that consists of
Mm-hmm.
almost like a virtual simulator device with those, anybody ever have a Walkman when they were younger, where you had the little
Mm-hmm.
headphones?
Mm-hmm.
So
Oh
it's like
yeah.
that kind of a device where essentially for about 60 minutes a day, around the same time each day, you're getting both visual and auditory stimulation, and the idea of that stimulation is to bring your brainwave activity up to the gamma wavelength, which is
Hmm.
ideal for memory and thinking. So, just to give you an idea of what that stimulation involves, so the visual stimulation is like wavy lines and different types of visual phenomenon. And then with the auditory stimulation, you've got like a series of clicking. The catch is you
Huh.
have to stay awake for this type of treatment. And if you do qualify in the initial stages of the treatment, you do actually have an opportunity to kind of test try the process. So we want to make sure that you're
Hmm.
able to tolerate this type of a treatment,
Yeah.
and you want to be able to know that you feel comfortable having it. So there is a test, trial, a test treatment as part of that
Yeah.
screening process.
Very interesting. I mean, and one of the cool things about that is that it's not a drug, right? It's not a substance you put into your body. It's a
Correct.
device that you wear.
Yes, it's a device that you wear. Again, pretty good safety profile. If there have been side
Mm-hmm.
effects, these have been things like usually headaches or tinnitus, most commonly.
Mm-hmm.
Tinnitus being ringing of the ears. Those things are reversible with withdrawal of the treatment. Generally we kind of try to screen patients and make sure that patients who are at risk for these things to begin with, maybe this isn't the best trial
Mm-hmm.
option. But for anybody who's like, I kind of want to be participate in something. I have, a lot of drug allergies. A drug trial that is investigational isn't for me, doesn't feel safe. This is one that is low risk. And the cool thing about it is yes, it's double blinded, but they do have an open label extension. So once you hit the 12-month period of not knowing what you're on, sham treatment or real treatment, you do have guaranteed treatment for another 18 months, which is neat.
That's very neat. I love that.
Yeah,
I'm
and the
gonna
initial
put.
data has shown that there has been
Mm-hmm.
roughly at that 18-month period of time that there has been roughly a 27% slowing of disease process, which is pretty
Really?
incredible because that's equivalent to the monoclonal antibodies that are on
Yeah,
the
yeah. I
market
was
that
just
are
gonna say,
approved that have
very
a
interesting.
much more severe side effect profile.
Yeah, interesting. I mean, I think to the point we were discussing before, I can imagine a world where you're on a monoclonal antibody and receiving the device. I mean, the other thing that is really great about the potential of a device is that there's the potential for common mechanisms, right, to be addressed. So not just
Yes.
Alzheimer's disease, but if you have dementia with Lewy bodies, for example, or
Yep.
frontotemporal lobar degeneration, a headset like this yeah, device like this may be able to help kind of slow decline as well, is because it's probably acting on similar mechanisms or a couple of similar mechanisms that you would expect in Alzheimer's disease.
Yeah, so it's interesting. They're still trying to figure it out. Initially, I think they thought that there was an impact on amyloid, and then the initial data so far has not shown that. But they found
Mm-hmm.
some cool things along the way, and that, speaks to the point of the secondary endpoints where you're looking
Mm-hmm.
kind of investigationally at a couple of additional
Yeah.
things. And so they found that with this treatment option, patients overall had a reduction in just overall generalized atrophy or shrinkage of the brain,
Mm-hmm.
as well as
Mm-hmm.
the hippocampus. And then they also saw that patients had a normalization of their sleep cycles. So these patients actually had like improved
Huh.
circadian rhythms, which we're again, it's like, what is the mechanism
So
of this device?
interesting. Yeah, how did
Yeah,
that happen? That's so
yeah,
funny.
but I mean, you can't hurt because we know that patients with Alzheimer's, Parkinson's, a lot of these
Mm-hmm. Hmm.
neurodegenerative disorders have abnormalities in sleep. So it is kind of
Yeah.
important to be able to address multiple areas at the same time. So we'll see what happens with that data. Um,
Yeah.
yeah.
Yeah, I'll shift gears here and move on to some observational studies that are open for enrollment. So the first one that I'll highlight is ALZNet. So this is the Alzheimer's Network for Treatment and Diagnostics. And so this is run by the American College of Radiology and the Alzheimer's Association. And it's essentially a nationwide patient registry that's collecting real world data about what it is to be a patient or somebody who's experiencing kind of Alzheimer's disease. And the main kind of inclusion criteria for that is that you're being considered for a novel therapy. That might be a monoclonal antibody like lecanemab or donanemab. It could also be brexpiprazole or Rexulti is another kind of new, it's not a new medication, but it has a new indication with the FDA for treating agitation Alzheimer's disease. And I think one of the things I really like about this is that it is a Centers for Medicare and Medicaid Services approved registry that if you become involved in this registry, you will kind of qualify for getting some assistance or some drug coverage under Medicare for the monoclonal antibodies, these amyloid targeting therapies. Isaac Health is a participating site of ALSNet. So if you are interested in joining ALSNet, please reach out to kind of a member of the care navigation team. We would love to speak to you more about it. Two other kind of longitudinal studies that are of note. One is ADNI. ADNI is kind of a stalwart within the kind of the longitudinal studies for Alzheimer's disease. It's as the name implies, the Alzheimer's Disease Neuroimaging Initiative. It's a very kind of neuroimaging focused cohort, but they collect all sorts of data. And what's useful from this study is that it has really informed so much about clinical trials and in clinical practice. And the data set in of itself is available to other researchers too. So you, by participating in ADNI, you actually have to contribute into all sorts of research, not just the single kind of ADNI cohort. And you also have access to all sorts of really novel imaging studies as well. Then there's the LEADS longitudinal kind of cohort. So it's a longitudinal early onset Alzheimer's disease study. So if you are somebody who has early onset Alzheimer's disease or is at risk of early onset Alzheimer's disease, this could be a cohort for you. Right now, the cohort's recruiting people who are cognitively normal to be a 1 year comparison. But I think one of the things that's worth exploring within any of these cohorts in terms of inclusion exclusion criteria is sometimes they're looking for people who have symptoms, and sometimes they're looking for people who don't have any symptoms at all or are cognitively unimpaired. And it's just a matter to see kind of what typical aging looks like. And if you do develop disease down the road, they'll be able to do some additional kind of studies on top of that to help to inform kind of what might have led to the risk for developing disease. Or what I think is also always kind of exciting is if you don't develop a disease, what was it about your life that led to protecting you? And that's how we learn about a lot of these modifiable behavioral factors. I don't know if you want to add anything about the observational study landscape, Dr. Patel.
Um, Only that we have one observational study too that we just started recruiting for, and this is a really neat study. It's the BioHermes 002 protocol. And
Mm,
what that basically what we're doing during that process is patients get a blood-based biomarker for Alzheimer's, the p-tau217. And if they come back positive for that result, then they get like the full gamut of workup. And some of these things are still under investigation, but you've got an amyloid PET scan, a tau PET scan, an MRI. We're doing something called the Red spec assessment.
mm,
We're doing cognitive view assessments. We're doing gait and balance assessments. Like it's basically a study that has all kinds of different diagnostic assessments. And some
mm-hmm,
patients are like, that's for me because I'm not really ready for an intervention yet, but I'd like to
mm-hmm.
know. And I'd like to know kind of where I stand in terms of having a thorough baseline. And I think that's an amazing, amazing opportunity. because you're getting $1 million workup at no cost.
Yeah, yeah. Yeah, you're getting like the billionaire workup.
Yeah. So, and there are a couple of other studies out there that are observational too. Like I know the ESI for the lecanemab prevention
Mm-hmm.
study, ESI
Mm-hmm.
ahead
Mm-hmm.
for patients who had
Yes.
screen failed, who did not have the blood-based biomarker for Alzheimer's, were invited to participate. Some patients, not all, were invited to
Mm-hmm.
participate in something called the APEX study. But I
Mm-hmm.
think these observational studies are really important because they're important for patients who don't want intervention, and they're
Mm-hmm.
also important for patients who may want intervention or maybe don't even qualify for intervention right now, but may in the future. Because oftentimes these studies are feeder studies for studies with intervention, optional, of course. But yes.
Yeah, yeah, absolutely. Well, there was also several other kind of studies that you're enrolling for at ERG and in Brain Matters Research. Do you want to share a little bit about these?
Yeah, so again, you've got a couple of options there that have out-of-box mechanisms of action. So actinogen is one of those. This is a study for patients with mild to moderate Alzheimer's dementia, and it's a
Mm-hmm.
study that is looking to reduce cortisol levels in the brain specifically.
Mm.
And so
Oh.
the rationale behind that is that we know that patients with Alzheimer's through prior CSF studies have elevated levels of cortisol,
Mm-hmm.
and that reducing the cortisol, we think, might potentially impact things positively from a memory standpoint. So they
Right.
took patients, and this is an Australia-based study. They just added a few sites on in the U.S., and Brain Matters happens to be one of the lucky few.
Mm.
Basically, what they found with the studies, the study data for the first 6 months, was so positive in terms of symptomatic treatment that they said if that was extrapolated out to 18 months, these therapies might be even 8 times more effective than the anti-amyloid treatments that are already commercially out on the market. So
Mm.
again, that's a little bit of a stretch because we only have a short time point, a short duration of data. But definitely a promising treatment, has been well tolerated, no serious side effects, no side effects warranting hospitalization, no
Mm-hmm.
treatment emergent adverse effects that have been associated with that drug specifically. And it's working to inhibit an enzyme in the brain that converts inactive cortisol to active cortisol. So it's working specifically on that enzyme and is not known to have peripheral side effects, which is great.
Mm.
The ITI study, the intracellular therapy. So we actually have two studies
Mm-hmm.
from that sponsor. One is not on there, but one is for agitation and one is for
Mm-hmm.
psychosis. All
Mm.
three of these studies, by the way, the actinogen and the intracellular therapy studies, are great because for patients who are a little bit more impaired or have claustrophobia and can't undergo imaging,
Mm-hmm.
these studies do actually allow a CAT scan, which is also kind of
Oh,
unusual in this day and age.
that is
So
unusual. Yeah.
yep. So patients who have metal in the body, who have pacemakers, loop devices, loop recorder devices, bladder stimulators, things that are not necessarily MRI
Mm-hmm.
friendly, can participate in those studies and have inclusion through a CT CAT scan. Um, so those are cool because again, it's like there's been this expansion in the market of the small molecules, and you're looking at a lot more treatments that are either symptomatic or that are targeting neuropsychiatric components of the disease. So the ITI studies are really neat because we know, and I'm sure if you're out there as a caregiver of a loved one with behavioral symptoms, agitation and psychosis are burdensome.
Mm-hmm.
And the treatments that are on the market right now, yes, you have breviprexol that was approved in 2023, but then you've got treatments that are typical and atypical antipsychotics that have black box warning in terms of increased
Mm-hmm.
mortality risk. You also have risk for extrapyramidal symptoms and so forth. So these are great options for patients who are, maybe have milder symptoms and are okay with disrupting this state of equilibrium that you might have with typical or atypical antipsychotics.
Mm-hmm.
Great option and great way to have good safety surveillance in a monitored setting. The Bristol Myers Squibb study, just to take a slight change of pace, that is a study
Mm-hmm.
that is a monoclonal antibody, a biologic, but it is targeting tau. So it is targeting tau
Mm.
tangles and looking to clear those from the brain. And that study involves monthly infusions. And again, entry for that study involves both a blood-based biomarker and then also a tau PET scan clarifying, I should say,
Mm.
diagnostically clarifying that that pathology is present before targeting it.
Yeah, I love
Then
hearing about more and more of these tau targeting therapies, because I think that's another kind of element of treatment.
yeah, absolutely. So there's that, and then there is and again, like you said before, just not to go too far off topic, but you're really,
Yeah.
I think, going to see that there isn't a cookie cutter approach. Every patient is different.
Mm-hmm.
Everybody's
Yeah.
risk factors are different. What you do within research is one thing, what you do with commercial therapy is another thing, but then also what you do
Mm-hmm.
with diet, lifestyle, exercise, all of those things are
Mm-hmm.
important too. And you really want to have the right specialist who's going to give you all recommendations across the board that
Right.
apply to your situation and that are doable and sustainable. Um,
Right.
so then the Karuna study, that is also another study for psychosis. So, and then the psychosis in AD, obviously. And then the GlaxoSmithKline study actually has just paused enrollment. But that is a
Mm.
study that is slightly different. It is a monoclonal antibody, and it is looking to upregulate this progranulin. And that's a slightly different mechanism of action, but again, consists of monthly infusions as well.
Got it. Got it. Yeah, so all these different mechanisms. You this
Yeah.
biohermes, which you had mentioned before for the observational study.
Yeah. Oh, and then you've got okay, so then you've got Lilly LAKI. So that is a neat opportunity because we've referred to donanemab a couple of times during this presentation. So it turns out
Mm-hmm.
donanemab has kind of I like to say like the bigger, badder, like Marvel superhero version,
Mm-hmm.
slightly different in composition, but sister agent, which is
Mm-hmm.
remternetag, and
Mm-hmm.
Remy, as the Lilly people say for short
Yeah.
for remternetag, has been looked at in early Alzheimer's disease. And again, like that's a really neat agent because we're seeing more rapid, effective clearance of amyloid than donanemab that is already approved.
Mm.
But then you're also seeing a better side effect profile as well. And so this
Wow.
particular opportunity is for patients who are looking to prevent Alzheimer's, and then those patients that are kind of in the early MCI spectrum of the disease process. Prevention as in preclinical, meaning you've got evidence of disease process as far as amyloid accumulation, but maybe not symptoms consistent with Alzheimer's just yet.
Mm-hmm.
Or those patients who have mild symptoms, but really no major impact on daily function and activity. So, independently functioning and so forth. So that's a really neat opportunity, and that is enrolling. You've got HBEO, and so this is a study. This is for symptomatic treatment. This is for patients with mild to moderate disease. The Merck study is also a symptomatic treatment. It is looking to actually enhance acetylcholinesterase therapy. So the one that we're most commonly familiar with is probably Aricept, and it is looking
Mm-hmm.
to amplify that effect essentially by working on one of the nicotinic receptors. Um,
Mm.
so that one's really neat as well. And again, that's for mild to moderate dementia. In the thing that I wanted to point out about the Merck study and the HBEO study, these are
Mm-hmm.
also really neat studies because, again, you don't have to undergo MRI imaging. You see, like with the monoclonal antibodies, we're
Mm-hmm.
looking for CNS side effects like bleeding or swelling in the brain. We're not looking at that kind of a side effect profile with these. So, for patients who can't sit through a 45-minute long MRI, who have claustrophobia, who just for whatever
Yeah.
reason don't want to do imaging, can't do imaging, these are great opportunities, and they are actually for mild to moderate disease process, mild to moderate
Wow.
dementia. And so,
Mm-hmm.
again, we're
Mm-hmm.
seeing a change in this field because most opportunities traditionally have been targeting mild early stage disease or maybe
Mm-hmm.
prevention. Now you've
Yeah.
got more options for patients who are in that mild to moderate dementia range.
Yeah.
Um,
No, it's great to have more options for people across the whole continuum.
yeah,
That you're right. It is great to see that.
Yep, absolutely. And then the PROMISE study, that's you've got another monoclonal antibody, and that again is it's an early phase study, phase one. The major, drawback of this study is that it does require CSF collection.
Wow.
So most of
Mm-hmm.
my patients, when I say, "Would you like to do a spinal tap?" they say, "No, thank you." But we have a good conversation about what the benefits may be, and
Yeah.
in this
Yeah.
particular case, we know that patients who are in the MCI early cognitive impairment range, for
Mm-hmm.
them, an amyloid PET scan may be negative, but the CSF may actually be more accurate. And if we're looking for accurate diagnosis, while the study sponsor will not release the specifics of the CSF, we do find that, but we can do the spinal tap through the study sponsor, and then
Mm-hmm.
still send out the fluid, collect extra fluid, and send it out for separate analysis. And you really
Mm-hmm.
are saving on the procedural costs as far as undergoing a spinal tap under fluoroscopy, for example, which can be
Yeah.
costly.
Yeah.
So
Yeah. Yeah.
that's an advantage of this type of option.
Wonderful. Great. So, I think one thing that I say that I'm taking away from this conversation is that there's a lot of options out there. So if you are interested, some kind of potential next steps, I would say talk to either your doctor or your provider at Isaac Health, or your care navigator to learn more about kind of different studies that can become available to. We can refer you over to Brain Matters Research and kind of the ERG group kind of at large. To kind of identify potential studies that you would be eligible for. Each study is different. They each have their own inclusion exclusion study, and we can kind of help to figure through some of that before you refer you over, so that way you know that you're more likely to get into a study if you're referred over. I think the other kind of potential resource that I'll just say, not to stop sharing here, is that there's the trialmatch.alz.org is another kind of resource. So we're always happy to kind of walk you through that process. So I would say, big picture, just reach out to your care navigator, your provider, and then let them know that you're interested in research either at your next visit, or just let them know now, and then they can connect you to the right person to share a little bit more detail on that. And now I'd like to transition to questions. You might notice at the bottom of your screen, there's a little QA, a little question mark button. So we encourage you to submit your question to that. Just click on the button and enter your question. I think we do have some questions already over here. But I'll just give a moment for people to add some additional questions. All right, so the first question I see here is, and I'll kind of direct this to you, Dr. Patel. So, are clinical trials safe? How is your safety and well-being monitored throughout the process?
I'm sorry, I didn't catch the last part. Is it how is your sleep
Uh,
being monitored?
how is your safety and well-being monitored throughout the process?
So I'm still not hearing you right. How is the what being monitored?
Your safety and well-being.
Oh, okay, very good question.
Yeah.
I'm yeah, I'm going to be honest with you on this one. I mean, clinical research is not for everybody, and I think you have to be
Mm-hmm.
willing to take on some risk, right? And I think you're looking at some risk, if you were to take an Advil or an ibuprofen or an over-the-counter medication, you're still taking on risk, right? And so I
Mm-hmm.
think it has to be really like a person-dependent decision. And I think, I mean, I can't say how other sites, or I can't really comment on how other sites are handling this, but I can tell you that when you come to Brain Matters Research, you're going to be there for at least a couple of hours. And that's because not only do we want to gather information to make sure a clinical trial is safe for you, but we all
Mm-hmm.
also want to be able to make sure that we understand your needs properly and that we find the option that best meets your needs, right? So if you're somebody who's risk averse and is like, I'd like the lowest risk of side effects, then I'm going to look at something like the device study or maybe the vitamin study and say, okay, well, maybe those are low risk options for you.
Mm-hmm.
But again, research is not for everybody, and that risk is not worth it for everybody. And some people have medical conditions that kind of prohibit them from really being in research, either through the exclusion criteria or just per my recommendations that it's just not a good option. So,
Got it.
and I
Great.
don't know if I'm answering the question properly, but I mean, protocols are really built, and IRBs are built to kind of protect your interests and to
Mm-hmm.
protect your
Mm-hmm.
safety. So the inclusion exclusion criteria, while many people look at that and say, "Ooh, well, my loved one or myself, I was rejected from research, or I wasn't given an opportunity in research because I didn't meet criteria." I don't really want you to look at it that way. A lot of those reasons for exclusion are really built in to protect safety.
Mm-hmm.
So whether it's, you can't be on certain medications because there's a possible drug-drug interaction with the investigational agent, or you've got advanced chronic kidney disease, or you've got one kidney and this potential drug could, cause, toxicity to the kidney that you have. There are usually good reasons for why you shouldn't participate from a medical stability standpoint. And so it starts with the
Mm-hmm.
inclusion exclusion criteria and these sites evaluation of whether you're a good candidate from a medical stability standpoint. And
Yeah.
then
And
that
on
obviously
that.
that's a continuing
Mm-hmm.
process as well. It doesn't just
Right.
start when you enter a clinical study. Our site prides herself in maintaining safety above all else at every visit, at every time that you're at Brain Matters Research through the participation in the clinical study.
Yeah. Yeah. And here's another question. What if I'm taking a blood thinner or any other medication that I might be on, how does that affect my ability to participate in trials, and how does that influence my safety?
Really good question. So that doesn't really affect you negatively in terms of your ability to qualify for a study. But I would say that when we're looking at monoclonal antibodies specifically targeting amyloid, we want to be careful because with some of these agents, we're not exactly sure what the risk is as far as risk of bleeding from these agents. And there is thought that there could be increased bleeding from, increased risk for patients who are on blood thinners. So
Mm,
that's one thing to be aware of. And then you also have to be really careful because these agents, the same agents I just referred to, the anti-amyloid monoclonals, can cause, as we mentioned, swelling or bleeding in the brain. The bleeding is usually small microhemorrhages, which are 1 millimeter, tiny, not small enough to cause symptoms, but the swelling can present with stroke-like symptoms. So when you go to the emergency room for stroke-like symptoms, which I hope you do, or you call, EMS
mm,
911 immediately, because time
hmm.
is brain. When you go, you want to make sure that you mentioned that you're in a clinical study and also that you're on a blood thinner because this could impact your treatment in those scenarios.
Great points. And then one last question I have here, which is what happens to data that's collected during clinical trials?
Lot. so,
Yeah.
so basically, let me give you the simple answer, I guess. So the data that's collected through clinical studies, there's a lot of different data from the standpoint of safety, and I
Hmm.
think this is also answering the question that was asked previously. And that safety is
Hmm.
based off of labs, biomarkers, which are markers for the disease
Hmm.
process, EKGs, MRIs, CAT scans. So there's that data. And that data is looked at by the sponsor on a regular basis, but it's also looked at by independent safety committees as well. And so from time to time, you'll see that there's a periodic analysis of this data to see if there's any kind of new safety signal. We
Hmm.
also have, sites are obligated to report any side effects that require hospitalization or are life threatening. So that data is looked at and is reported to the IRBs. And the IRBs are, in a nutshell, are institutions that are there to help protect participant rights and safety and well-being.
Hmm.
So they
Hmm.
want to
Hmm.
make sure that sites and protocols are, to the benefit of the patient and that they are preserving safety above all else. And then you've got other data, you've got efficacy data. And so from time to time, you will have these interim database locks. That means that whatever data you have, that data is frozen and it is analyzed by the study. And again, sometimes independent committees looking to see if the study is looking like it's going to meet the endpoints that it's looking to meet. And sometimes we're so far off the mark that these studies end early. And that's the honest truth of it. They end early because of lack of efficacy. Most of the time, because of lack of
Hmm.
efficacy, not because of a safety concern. But I hope that
Yeah.
answers the question.
Yeah, no, I think that's super helpful. Well, not seeing any other questions. I think we can give people some time back. And I'll just say thank you, Dr. Patel, for joining us today and sharing with us a wealth of knowledge about all the different trials that are available, the different treatments on the horizon. I think for me, this just shows that there's so much hope here, and there's just so much moving in the field now, way faster than it had been in the last several decades. It's just very, very exciting. That's just for Alzheimer's disease, for all conditions that can impact cognition. And thank you to everybody here who attended this webinar today. Thank you so much. If you have any other questions or need any other resources, don't hesitate to reach out to us at Isaac Health or with your care navigator specifically. We're here to help. And other than that, take care, and we look forward to seeing you at our next webinar. Take care.
Sure,
Have a good night.
absolutely. And if anybody has any additional questions that I couldn't answer or that they wanted, a different or more comprehensive answer to, they're more than welcome to email me as well. My email is ppatel, so that's two P's,
Hmm.
ATEL, at ergclinical.com. And you're more than welcome to email me anytime, whether you're interested in research or not. I'll do the best I can to help you.
Wonderful. Thank you so much for offering that. And
You're welcome.
thank you again. Take care.
You're welcome.
Bye
Thanks for
bye.
having me. Take care.